Hello, I'm Hunter Rooks. I'm a fifth-year resident at the University of Tennessee. I am finished a surgical critical care fellowship, and I'm here today to talk to you about chest tubes and thoracic decompression. I'd like to thank the Trauma Symposium Committee for inviting me to give this talk to you today. So let's get into it. First, I have no disclosures. There are no companies paying me to be here or represent their products. And I'd like to make sure you know any branded products seen in this presentation are examples based on available quality images and do not reflect any specific recommendations for your use or your choice of products in your practice. So what are we going to talk about today? A little bit of the history of chest tubes. We're going to talk about the anatomy of the thorax, how to decompress the chest by a couple different methods. We'll talk about placing chest tubes. And then what are the current guidelines based on the literature and governing body recommendations? So what are chest tubes? Chest tubes are some form of a tube of various composition, often stylastic, that are placed into the chest to decompress or drain the chest of air, blood, or other fluids. So how do we get around to using these? Where does the history of chest tubes begin? From the data I've been able to gather, this begins around the 4th century. Hippocrates drained empyemas. And in the 11th century, Mitchell first discussed using these in a trauma patient. Baldwin I was injured by a lance, and he used a tube to drain pus from the wound. In the 13th century, Eschenbach wrote a tube thoracostomy to treat tension hemothorax after a jousting injury. In the 16th century is the first notice of using chest tubes after ballistic injuries by De Vigo. In the 17th century, a suction apparatus connected to a tube, or in this case, wound suckers, people who would remove blood from the wounds, was used. In the 18th century, syringe aspiration as an additional form of sucking was used to remove fluid from the chest cavity. And in the 19th century, our modern water seal system that we currently use today was first described. So let's talk a little bit about the anatomy. So as you see here, there are two representative images of the chest. The image on your left shows you many of the skeletal parts of the thorax, including a few nerves. And the image on the right is going to show you a little bit more of the intrathoracic anatomy, including the lungs, the heart. So if you notice here, and focus on the image on the left. You can see the pectoralis major here. You see the latissimus and the serratus muscles. And you see this triangle where there seems to be fewer overlying muscles on the serratus. We'll talk more about this later. Of note, pay attention to these nerves here. And in the image on the right, you see your lungs within the thorax. You see your ribs, your intercostal muscles, the pleura, and the lung in here. Of note, the heart and the great vessels are medial to the lungs bilaterally. More specifically, the primary focus when placing a chest tube is emphasizing the intercostal space. Note here that there are two ribs, a superior and inferior rib, and an intercostal vein, artery, and nerve. You'll notice the larger bundle of these, the primary bundle, runs underneath the rib. And it's very important when placing chest tubes to preserve this neurovascular bundle. That's why, and we'll talk about this later, when placing a chest tube, it is important to go over the rib as opposed to underneath the rib, and reducing the damage to these structures. Let's talk about tension pneumothorax. So these patients, especially in trauma patients, may present with tachypnea, air hunger, profound hypoxia, or less profound hypoxia. Folks who have true tension physiology, the clinical manifestations of this may become hypotensive. They have tracheal deviation classically, and absent breath cells on this side that the pneumothorax is on. A tension hemothorax has similar physiology, but instead of air in one side of the chest, it is blood. Note in the superior image, you can see here, this dark space here is air in the chest. Over here, you can see some lung markings, and then the mediastinal structures have been shifted. This is the heart. You see this more loosened structure is the trachea, and this has been shifted over. Again, if you look at the inferior image, you see the lung markings here, laterally underneath the ribs with its vascular markings. You see a significant whited out area on the left. This is blood. And if you pay close attention, you can see the heart is somewhat shifted this way. And the trachea, the right and left mainstem, come together here and sits off midline as well. So to treat these patients, we need to decompress the chest of either air, blood, or again, other fluids in the appropriate clinical circumstance. How do we do that? There's a few ways. Needle decompression is commonly used, commonly taught, especially to EMS providers. Finger thoracostomy, where instead of putting a needle into the chest, we make a small incision and put a finger into the chest to decompress. Tube thoracostomy, the classic chest tube. This is where an incision is made and a tube is placed into the chest to decompress. And a thoracotomy, although this is a very significant and very morbid procedure in a trauma patient, and this may be something that alleviates that tension, either blood or air, and additionally allows the provider to address potential underlying injuries within the chest cavity. So let's talk first about thoracic decompression. So needle decompression, classically, this is taught to be placed anterior in the second intercostal space at the mid-clavicular line. As you can see in this image here, you see that the needle is placed through the soft tissue and muscle, entering the chest cavity, allowing air to be removed through the angiocatheter and allowing the lung to rise up, reducing the tension physiology. Current guidelines now say instead of the second intercostal space, we are moving towards the fifth or fourth intercostal space at the mid-axillary line. Of note, this is where we classically place chest tubes. One of the reasons for this is that these catheters do not always reach the chest and can be unsafe or ineffective, and neither of those are helpful to patients. A finger thoracostomy is another form of decompression, as we discussed, where a small superficial incision is made and a finger is digitally inserted into the chest, decompressing the air or blood bluntly without adding any additional objects that could be sharp or more damaging into the thoracic cavity. Let's talk about chest tubes now. So how do you select them? This will differ depending on whether you're draining air, blood, or simple fluid. The typical chest tube design, as you see here, is a large cytoplastic tube of varying sizes, and this has multiple holes for draining either, again, air or fluid. Note here in the red circle at the top that there is a sentinel hole or sentinel eye. And this, we'll talk more about later, is a marker that you must have all the way into the chest. There's also a body that shows distance markings. These are graduated, so you know how far in the chest these tubes are placed. And a tapered tail, as you see in this third image, that we'll talk about later when connecting to the atrium. But of note, there's a hole in this, which allows for flow in and out of air, and again, assists with decompression, reducing any kind of tension physiology. This bottom image, you see, again, a chest tube, although smaller, with its sentinel hole highlighted with the red circle. There's an additional tube, this white one, and this is known as a pigtail catheter, which is a much smaller, less invasive drainage catheter that can be placed and often can have a similar treatment effect. This is known as a pigtail catheter for its similar shape to a pig's tail. So where do we put these? And we touched on this earlier, but let's talk more in depth about this. Our classic location is approximately the fifth or fourth intercostal space along the mid-axillary line. More specifically, this is done in the triangle of safety. As you see here, this triangle is formed superiorly by the axillary fold, inferiorly by the fifth intercostal space. And on a patient, this fifth intercostal space can often be represented by the patient's nipple line or the inframammary fold. Of note, in patients with large body habitus, large amounts of breast tissue, large pendulous breasts, this line may be lower on the patient artificially when their fifth intercostal space may be more superiorly placed. So it's important to have a firm understanding of your patient's anatomy when selecting this, instead of going just by the nipple or intercostal space. Inferiorly, again, the nipple or fifth intercostal space, and then medially, we have the border of the pectoralis major, and laterally, the latissimus dorsi. So in this space, there are fewer muscles that are likely to be damaged, and you are less likely to have a significant nerve injury to the patient. So how do we do it? The first step, you apply local anesthesia. Again, this is in a less than emergent patient. Local anesthesia is given to reduce pain. We make an incision overlying a rib. Using blunt dissection tools, you dissect through the subcutaneous tissues down to the level of the rib. At this point, you then insert an appropriate instrument, typically a hemostat, potentially a pair of closed scissors, or a large Kelly clamp into the patient's thoracic cavity. This can also be done with a finger. It is important, as we discussed earlier, that the insertion site needs to be immediately above the rib. You should feel the rib and then put your instrument just over this into the chest, and then stop as soon as you have felt a pop into the chest. Again, this ensures that we are reducing our likelihood of injury to the intercostal nerve, artery, and vein, as well as reducing our likelihood of injuring any structures in the chest, such as the lung or the heart. Once you have made a hole in the chest, the instrument is then removed and a finger is inserted to confirm location. You can typically feel the lung or the diaphragm, and you can ensure that there are no adhesions or scar tissue of the lung to the surrounding chest wall. Once you're confident that you are in the chest, a tube can be inserted then through this hole into the thoracic cavity. And again, like we discussed, the sentinel hole is used to identify where our tube is within the chest, and this must be inserted all the way into the thoracic cavity, or air and blood will not drain appropriately. Once you have this inserted and secured, you can connect the chest tube to an atrium or the suction device, and this will allow the fluid to be evacuated with vacuum suction and the lung ideally inflated. The tube must also be secured so that this does not come right back out of the patient and be forced to place another one in a more emergent setting. This is a video by the ATLS Society discussing and showing how to properly place a chest tube.
The first step in the placement of a chest tube is to identify the insertion site. The insertion site is the fifth intercostal space just anterior to the mid-axillary line on the affected side. This can be found by using the nipple level as a landmark for the fifth intercostal space. In females, always be aware that the nipple may be displaced inferiorly due to large pendulous breasts. In this case, remember to stay above the inferior mammary fold where the nipple would normally lie. With the patient lying supine, position the hand up and over the ipsilateral shoulder and secure it in this position to keep it out of the surgical field. Surgically prep and drape the chest at the predetermined site of tube insertion. Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transverse incision parallel to the line of the ribs at the predetermined site with a number 11 scalpel. Bluntly dissect the subcutaneous tissue with the scissors or hemostat. Dissect over the top of the underlying rib until the next highest intercostal space is encountered. With the tip of the hemostat, puncture the parietal pleura while pushing just at the top border of the rib. You must always enter the pleural space over the top of the rib to avoid damaging the neurovascular bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating the lung with the hemostat. Once inside the pleura, spread the hemostat widely and withdraw it while still open to create a sufficient opening in the pleura for the chest tube. Before inserting the chest tube, place your finger into the hole of the floor. Move your finger around 360 degrees to confirm correct location in the pleural space by feeling the lung and making sure that there are no adhesions or impediments to placing the chest tube. A large chest tube, a number 36 or number 40 French, is used in trauma to allow for the evacuation of blood and clots. Clamp the proximal and distal ends of the tube before insertion. The distal clamp will keep any blood from rushing out before it can be connected to a collection chamber. The proximal clamp will assist in chest tube insertion, but may not always be necessary or helpful. Advance the chest tube into the pleural space to the desired length. All of the drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. This will allow for maximum drainage in the supine position. It may be possible to see fogging of the chest tube with expiration, and it may be possible to listen for improved air movement on the affected side. Connect the end of the tube to an underwater seal apparatus collection chamber.
So again, it's very important once you have your chest tube placed to make sure that you know that it is not only where you think it went, but where it should be. As you can see here in this image, the tube is passed through the chest and up, placed superiorly at the near apical aspect of the lung. This is very appropriate position. Ideally, this would be placed posteriorly as well. However, on an X-ray, you're unable to tell. And so it's important that when placing these tubes, that you have an idea of where your tube is going when inserting it into the chest. Additional ways, more clinical methods for identifying this is things such as, has the patient improved? Is their tension physiology better? Are they less tachycardic? Are they less hypotensive? Are they able to breathe better? Is the trachea that was once previously off midline now returned to midline? Additionally, do you see blood or fluid coming from the chest tube? If this is consistent with the findings upon entry into the chest, and these may support your clinical suspicion that your tube is in the appropriate place. You may see fog in the tube as the patient breathes and their lungs move in and out, or when assisted using a ventilator or an ambu bag. You may see the fog from the air in the chest tidling through the tube. You can also see in the atrium or collection device, depending on your type of device, the water that is placed in the water seal moving with each breath. Again, as we discussed first, an X-ray is a very appropriate and often used modality for confirming your tube placement. So not all placing chest tubes is helpful to patients. There can be complications like any procedure we do. Of note, chest tubes have about a 3 to 10% rate of complications. Often these are injuries to the lung, occasionally the heart, vasculature, such as the intercostal nerve artery or vein. Injuries have been reported to the aorta or other major vascular structures. The esophagus, diaphragm injuries can also occur. If your incision site is too low, you may find yourself entering, instead of the chest, the abdomen, or by way of the diaphragm, traverse the chest into the abdomen. Should you find yourself in the abdomen, there are important organs that can be damaged. The stomach and spleen can be injured if you enter the left side of the abdomen, and the liver can be injured entering the right side of the abdomen. These can all lead to fatal bleeding events or other bleeding that may need additional procedures. So it is important to attempt, obviously, to stay within the thoracic cavity. Additionally, any foreign body can lead to an infection. The longer a chest tube is in the body, or the less sterile that the procedure is performed in, the increased likelihood of infection is present for that. Obviously, in our patients in emergencies, sometimes we must prioritize our patient's life over some of the sterility, but it's always important to try to maximize this whenever possible. Additionally, the tube may not be placed in the right location. Like we discussed, could be placed in the abdomen, But also this can be placed in the subcutaneous tissues, not unlike needle decompression. Occasionally these tubes are not inserted in the appropriate location. And that's why it's very important that you have digital palpation of the thoracic cavity prior to entering your tube, and that you have good confirmation that your tube is in the chest prior to assuming its position is correct. So what are the current guidelines? Now that we know how to put chest tubes in, should we be doing them? So let's talk specifically about the pre-hospital environment and what the recommendations currently are with that. We'll review the literature some on this matter as well. So there are two studies we'll start with first, this BET1 and BET2 study. The first showed pre-hospital finger thoracostomies in patients with traumatic cardiac arrest. This was a review of 3 papers using trained physicians in tube thoracostomy for patients that had arrested. Again, these are trauma patients. And this showed effective practice with no major complications over baseline in hospital. The second study showed finger thoracostomies in patients with chest trauma. This looked at 5 papers and reviewed these, again, using trained physicians at finger thoracostomy. And these were placed in patients who had suspected tension pneumothorax, again, trying to prevent further decline and potential cardiac arrest. And again, these papers all show that this was an effective practice, a safe practice for physicians to be performing in the field. So what about non-physicians? This is a study by Harrell et al. That looked at trained aeromedical non-physicians, compared 49 chest tubes placed by air ambulance providers with 98 hospital physician placed tubes. The time to placement was significantly shorter when placed by aeromedical providers, with no statistical difference in malposition or organ injury, showing that trained aeromedical non-physicians may be able to safely place these in the field and potentially do that faster prior to patient's arrival in the hospital. An additional study looked at 57 patients that had been traumatically arrested. Now this, instead of aeromedical providers, looked primarily at ground medical providers, your paramedics, your EMTs, and other ground providers. And this had folks that were trained through a regimented curriculum to provide tube thoracostomies. In patients with traumatic arrest, 75% of these chest tubes were placed in both sides of the chest, as opposed to 25% being placed in one side of the chest. Of those, 35% had air returned, which would increase your suspicion for a tension pneumothorax. 25% of these patients, importantly, had return of spontaneous circulation. And of note, every patient that had return of spontaneous circulation did have a return of air or blood, as opposed to entry into the chest without any return, any gross decompression. 7% of these patients that had return of spontaneous circulation were discharged from the hospital with a normal mental status. Again, any traumatic patient that arrests has a significant mortality burden. And in these patients, 7% of these were able to leave the hospital with appropriate mental status. There were some complications. 2 of these thoracostomy tubes were not placed inside the chest. There was a diaphragm injury and a liver injury. But overall, this seemed to have relative efficacy. So what does the advanced trauma life support say about tube thoracostomies and chest decompression? So current guidelines say that chest tubes and needle decompression should be occurring at the 4th or 5th intercostal space. Again, chest tubes have always been recommended to be placed in this location, but needle decompression has now moved from the midclavicular line in the 2nd intercostal space to the mid-axillary line in the 4th or 5th intercostal space. So that's an important note for people who've been doing this for a while. Typically, the recommendation is a 28 to 32 French chest tube. And this should provide adequate drainage of either air or blood found in the chest. Additionally, now, the focused abdominal sonography for trauma, or the FAST exam, commonly performed in the trauma resuscitation bay, now includes additional evaluation of not only the abdomen and heart, but the chest wall for presence of air and pneumothorax. If you look at the image over on the right, you can see along this video where it says pleural line. If you look carefully, you can see the bright white strip seems to move a little bit. This is indicative that the lung is opposed to the wall, and this movement comes with the patient's breath. In this image, you see the video with the bright white strip next to the arrow. And if you look closely, that white line does not move. And that raises the suspicion that this patient may not have lung apposition to the chest wall. Again, further raising your suspicion for a pneumo or hemothorax. And this is now part of our ATLS recommendations. So what are our local guidelines? Here in the Chattanooga, Hamilton County greater area, ground EMS providers, when patients are believed to have a tension pneumothorax, a needle decompression is the appropriate treatment for these patients. Trained air ambulance providers who have had training in chest tube placement may be able to do thoracostomy, either tube thoracostomy or finger thoracostomy, but needle decompression is also an appropriate treatment. And then physician providers in the hospital or in the field may place tube thoracostomies, provide finger thoracostomies for decompression or needle decompression, depending on how they see appropriate at that time. So where should we go from here? I think based on our studies, there seems to be some data that show a more beneficial approach, or at least a safe approach, for air and ground medical providers to be able to decompress the chest with not only needle decompression, but thoracostomy as well. This is something that would need to be explored more, but the current data says that this may be safe, particularly in patients who have already arrested or with major traumatic injuries, in whom the mortality benefit may outweigh any potential complications, as their risk of mortality increases with every moment without a pulse. It would be nice if we could get additional local studies and assessment of how training our EMS providers in this would be able to improve patient care. And additionally, a national assessment to see what the communities at large are doing and how we could implement this if appropriate. Thank you for your time and attention. I again appreciate the honor and privilege of speaking with you all today at the Erlanger Trauma Symposium. I hope this talk has been helpful to you and educational. And for any additional reference information, I'd be happy to speak with you more and provide those links. Again, have a wonderful day.